Dr. Dustin here. Tonight we have a very special episode, and it is entitled Pain Management is Risk Management. Okay, so I recently saw a video circulating on the internet that was used to identify a catastrophic situation. Call it a complication, really is a catastrophic complication from a spinal cord stimulator implant as evidence. The video was using this complication as evidence why we should avoid the therapy altogether. And it made me realize that we actually have a pretty big problem, and that is the understanding of risk. We have a risk literacy problem in pain medicine. And so today I want to slow this down. I want to talk about that and really bring it to a fundamental level, understanding that pain management is risk management. Okay. Now, what I'm about to say, all of you probably already understand, but it's worth saying again. There is no zero risk option in medicine. Procedures carry risk. Medication carries risk. Surgery carries risk. And doing nothing carries risk as well. The absence of intervention is not the absence of risk. So the question is never, does this carry risk? The question is, compared to what? And so when we're talking about something like spinal cord stimulation, certainly a spinal cord injury is a devastating outcome. And that is not something that any of us want. That's not something that should be minimized, and certainly it needs to be addressed. That is a risk of this procedure. Anytime we're accessing the spinal column, putting instruments and fingers and blunt objects and sharp objects next to a very delicate part of the spine, the spinal cord, or even all of the vessels, arteries, veins that surround that spinal cord, there's going to be a risk despite our best intentions, despite minimizing that risk as much as possible. And so to say that there's no risk to a spinal cord injury at all would be misleading and dishonest. So we're not saying that. But I can tell you that when that happened to that poor patient, actually I think it was a couple patients, which is, again, worth noting, and maybe we'll talk about that specific case here at the end. Trust me, everybody lost in that situation. The patient lost, the family's lost, the doctor lost, everybody's losing sleep over that situation. Well, probably not the lawyers, but that's another case, right? So, but we're going to talk about the real risks of interventions tonight so that we can understand what it's like to practice medicine in general, but specifically pain medicine, when it comes to the risks that we take, not only as physicians, but also as patients, and making sure that we all understand the risks that we're taking with the hopes that, hey, maybe we can get something better out of not doing anything. That should be the goal. So tonight, we're going to cover a few treatments that are commonly done in pain management. And this is not representative of your particular case necessarily as an individual patient. This is not representative of all the treatments that are available in pain management, but I picked three sort of to cover, let's say, the most talked about interventions that are done. The first, of course, is epidural steroid injections, very commonly done. If you're a pain patient, probably you've had one over the course of your time. Of course, we're going to talk about spinal cord stimulation. We're going to talk about opioid therapy because to ignore opioid therapy, I think, as a pain doctor is you can't do that. And so we're going to talk about that, and then we're going to talk about the risk of doing nothing, which also carries risk. So to begin with, let's talk about epidural steroid injections. Anytime a needle punctures the skin, a needle or a scalpel punctures the skin, there's always a risk of bleeding, infection, and nerve damage. Now, there's other things that can go along in risk. In those procedures, of course, you may have a side effect to the medication. If you get steroids injected, right, it can make you feel a little weird for a few days. It can cause your sugar to go up. And if you're, let's say, a brittle diabetic, it could even lead to diabetic ketoacidosis. You may even end up in the hospital to treat diabetic ketoacidosis. I have seen that one time, actually, in a patient. We were prepared for that to happen. But even still, that patient had normal numbers. It was a well-managed diabetic. Unfortunately, those things happen, but we talked about it ahead of time. But that's one case. It's still, not every situation, but those things happen. That's not what I want to highlight tonight. I want to highlight the big, scary stuff that is, let's say, irreversible. Specifically, irreversible nerve injury. Nerve injury, spinal cord injury, irreversible paralysis. As a patient, that's the big, scary thing that I would be worried about. Comment if you think something else would be of bigger concern. But yes, obviously death, but that I don't think is necessarily linked to the procedure or any procedure itself. There's lots of complicating factors that could lead to that, although the procedure itself could lead to that. But what we're talking about tonight is irreversible neurologic injury. And so when it comes to epidural steroid injections, when you think about how many injections are actually done on a year-to-year basis, we're talking tens of millions. Tens of millions epidural steroid injections are done in a year. And the risk of irreversible neurologic injury has been cited to be on the order of 1 to 5 per 100,000 injections. Pretty rare. Not zero. The risk exists. That's why we talk about it. That's why we talk about it in the informed consent. But again, it is very rare. 1 to 5 events per 100,000 injections. When it comes to spinal cord stimulation, there are other considerations worth discussing. One could be lead migration. This has been probably one of the most commonly cited complications historically because of how our surgical technique was over the years. I mean, this technology has been around for probably 50 years now. So you can imagine the advancements in medicine over those decades. In fact, it's commonly cited amongst the community of professionals that the advancements in spinal cord stimulation has been more in the last 5 years than in the 50 years prior combined. Okay, and that's a good thing. The problem when you have spinal cord stimulator lead migration, let's say we put 2 leads in your spine, and they're just free floating in there, right? So you just kind of hope they stay in place. And but over time, let's say due to less than ideal surgical technique or just living life, those leads can migrate and shift like so, right? And when that happens, the effectiveness of the stimulation goes away because we're no longer stimulating the one part of the spinal cord that we need to be stimulating in order to reduce your pain. So the result in most cases when you have lead migration is that you no longer feel the sensation. And that would result in treatment failure or surgical revision. So you have to go back to the OR. We have to open you back up again, minimally invasive, of course, and then replace or move those leads back into position, tie them down a little bit stronger or whatever have you. But that is cited as a complication, and it is a complication. But historically, that has been anywhere between 10 and 20% of cases. Now, that's not a small number. I mean, it is the minority, fortunately, but it's still a number worth considering. And but again, the technology has advanced so much that to see lead migration anymore is a relatively rare event. In my experience, it's less than 10, probably less than 5% of the cases now. And again, the reason why is because of 2 things. One is the surgical intervention. So we're getting better at anchoring the leads into place. We have special anchors now that we fit over the leads that screw down to hold the lead tight, and then we suture that to the fascia in your back, and that helps to hold the lead in place. That's number 1. Number 2, even if that fails for whatever reason, if the lead moves, now because we have better technology, there's more contacts on each lead, which means there's more real estate these leads can cover. And we also have the ability now to change the power output between the leads. So if, lead one, if contact one or contact two is right over where we want it to go, and then the lead moves a little bit, well, we can actually just move that power to contact one and compensate. So now we have the ability to compensate based on the technology in case there is any movement. So the complication of treatment failure is not as prevalent. That's a good thing. Another risk that is worth considering is infection, of course. And that rate is anywhere between 5 and 10%. Again, small, but not totally non-existent, right? It definitely exists. And let's say there's several factors that could contribute to that. Perhaps you're immunocompromised and we didn't know it. Perhaps we put the procedure in, and due to the stress of everything, right? You're in a lot of pain, maybe on a lot of medicine. You haven't been sleeping well. Your immune system is poor. And maybe you're a diabetic, even if it's controlled, so your immune system is compromised. That does increase your risk for infection. But your doctors should talk to you about that. That should be part of the informed consent. And there's mitigation things that we can do. We can provide you with antibiotics either before or after. I did have one infection in all of my spinal cord stimulator implants. And incidentally, that patient, I guess, didn't quite understand the discharge instructions and took the bandage off as soon as they got home and started picking around at it and all these types of things. And I about had a panic attack. I'm like, don't touch it. And he came back a few days later and there was an infection there. So there are things that can cause infection, whether, we are mindfully doing it or subconsciously interfering. So these are the things that, can increase the risk. But again, on average, across the board, let's say 5 to 10%. Hardware issues is another one, right? Again, 5 to 10% of the time, you'll have hardware issues. Perhaps the device itself was faulty before even implanting it. Perhaps it was buried too deep in the skin. And if you have a rechargeable battery, that conductance across the skin and soft tissue may be too far. Maybe it's not getting a great connection and the battery starts overheating, right? Have you ever tried to charge your phone on a contactless phone charger and it wasn't quite sitting right and you come back and the phone is super hot? So those types of things can contribute to hardware issues as well. And of course, the very rare neurologic injury, which I know you all are very interested in hearing about because this is what makes the news. When certain advocacy groups are talking about the risk of spinal cord injury when it comes to spinal cord stimulation, the implication is that it's permanent paralysis. And again, while these events are devastating, it's so rare we don't even have numbers for it. Let me get it in, put it in perspective for you. So the best incidence estimates, they come from large claims database studies, and they include everything from transient deficits, meaning that maybe right after the surgery you had a little bit of weakness, but after a few days, maybe a week or two, it got better. It includes those patients all the way to severe outcomes, permanent paralysis. And what they found, there's two commonly cited claim-based studies estimating that the rate of spinal cord injury after a implant of any lead type, meaning that there's leads that a pain doctor can put in that are just two little noodles, essentially, and then there's leads that a neurosurgeon can put in, which are shaped more like paddles. And so regardless of the type of lead that is implanted, the rate of spinal cord injury, again, transient or permanent, is about 0.42%. Again, very small number, but that's still a real number in my head. It's still a real number. Another large data set analysis reported 2.13% spinal cord injury, again, temporary or permanent, because we can't differentiate that when it comes to complaints of spinal cord injury. Any spinal cord injury is a spinal cord that is injured. Is it inconvenient to say the least? Is it scary to say the least, even if it's transient? Yes, absolutely. Is it terrible? Is it life-changing if it doesn't get better? Absolutely. But when it comes to the claims data and how we can estimate these things, we don't know which ones are permanent or which ones are transient. The implication is that most of them are transient. So another large data set looked at, again, several thousand of these implants over the course of several years, and they came up with a 2.13%, just over 2% incidence within 30 days after implant. Now, so the range, we're looking at about 0.4 to about 2%, depending on how you define it. But again, this is not the same as permanent paralysis. Now, before you say, oh, I'm just hawking for spinal cord stimulation, hear me out. I am not. I'm just trying to give you real numbers so we can understand and have an engaged conversation. Okay. Now, when it comes to reports of persistent permanent paralysis, these numbers are pretty much constrained to case reports. And there's been approximately 3 over the last 10 years. When you consider that on the scale of anywhere between 30 and 50,000 stimulators being implanted per year, 2 to 3 case reports really is a very small number. And that's why we don't have large claim sets, claims data supporting permanent spinal cord stimulation or permanent spinal cord injury numbers. We just don't have it. Now that we understand that to some extent, let's think about this in the context of those who benefit. Again, 30 to 50,000 implants or trials are done per year. Now, the conversion of trials to permanent implants is approximately 60 to 70%, which means that those who underwent the trial found so much relief with it, defined as in the definitions, defined as at least 50, in most cases perhaps 80% relief of their typical pain symptoms, right? 60 to 70% of them said, hey, this is really great. I want to go forward with the permanent implant. Now, when you think about 60 to 70% on a scale of 30,000 to 50,000 done per year, that's tens of thousands of patients that benefit significantly from this treatment. So spinal cord stimulation has a small but real risk of neurologic injury, especially tied to the implantation procedure. But permanent paralysis reports are confined to rare case reports. We don't have epidemiology. Thank you. Epidemiologic incidence rates. We don't have that. Looking at large scales of numbers, we don't have that. So, in most cases, the expert consensus is the risk of permanent catastrophic neurologic deficit is well under 1% and likely far below 0.1% in properly selected patients. And they looked at this. They saw, okay, well, who are the patients that are getting even transient neurologic injury? Who are those patients? Well, for whatever reason, they're most likely to be men. So congratulations, men. Why, I don't really know. But the next thing they looked at is the presence of spinal cord or spinal stenosis, which means narrowing around the spinal cord that already is there. And so that's part of the reason why we get MRIs. We want to make sure that there's going to be room to install 2 wires above your spinal cord. If there's already disc or bone pushing on that and there's no room, and then we're jamming in 2 wires between the bone and the spinal cord, that would be a problem. And so it makes sense that those patients are going to have an increased risk for spinal cord injury, whether permanent or transient. Another thing they looked at is the presence of anticoagulation. So if you are on warfarin or heparin or Xarelto or Eliquis, and maybe you didn't stop it ahead of time or whatever have you, again, that would be a failure on your medical team to ensure that that was not the case, that you stopped it in enough time before the procedure. That would put you at increased risk for bleeding. Bleeding develops into hematoma, puts pressure on the spinal cord. You have spinal cord injury. So again, for whatever reason, being a man increases your risk. Having spinal stenosis increases your risk. And being on blood thinners. So all these things makes sense. But this is part of the informed consent. Okay, this is part of identifying the right patient. And, as I continue to talk about this, understand that these risks may not apply to you. You may have a higher risk than what these large data sets suggest, because these are, let's call it a population average, so to speak. Right. And so if you're, but you're not the average on the population, you are you. And again, this comes back to the understanding of individualized care. If you're on a blood thinner and you need that blood thinner to live, is it worth stopping the blood thinner in order to do a stimulator? Well, that's again, based on the conversation that your doctor will have with you. So understand that as well. These are large scale statistics. But we have to rely on these to some extent, not only to make informed decisions for you, but so that you can have informed decisions as well, right? So, again, the risk of complication with epidural steroid injection is very small, but not zero. The risk of complication with spinal cord stimulation is very small, but not zero. Let's talk about opioids, right? There's lots of complications with opioids other than what we all talk about, which is addiction and overdose. Now, even that is a big enough complication, but there's more things to it. There's health problems. There's hormonal suppression, right? There's cognitive slowing. There's increased risk of fall, constipation, and then, of course, the famous opioid-induced hyperalgesia, right? All of these things are risks or complications associated with long-term opioid therapy. The risk of addiction, again, when you're talking about tens of thousands of patients, let's say, being treated with opioids, the risk is not less than 1%. The risk is anywhere between, the most recent studies since 2016 show a risk of addiction, let's say, anywhere between 1% and 5%. Well, okay, let's say 1%. Well, that's still an order of magnitude greater than 0.1%, let's say, with spinal cord stimulation. It's still 10 times the risk of addiction with opioid therapy than it is with spinal cord stimulation. But again, keep in mind, this is across the board. Some patients do very well with opioids. Some patients can manage their symptoms or their pain or their medications or whatever. They can manage for years very effectively, right? And so this is not to say that spinal cord stimulation across the board is safer than long-term opioid therapy. Incidence data, large-scale incidence data looking at tens of thousands of patients would suggest, yes, that is true. Across the board, spinal cord stimulation is likely safer than opioid therapy. But when you apply that to individual patients, it may change. Some patients should never have a spinal cord stimulator. Some doctors should never put in a spinal cord stimulator. Some doctors should never prescribe opioids. And I mean, we all know those doctors. Some patients should never have opioids. The risk might just be too high for that individual. So again, that's part of the nuance. That's part of the experience of actually practicing in this space that a physician has to take into account. And then, of course, there's the risk of untreated chronic pain, severe chronic pain that goes untreated, right? That is the most heartbreaking scenario to me, but it's still a risk to do nothing. And again, I don't have to tell you, but think of the complications that can come from doing nothing. Not only do you have increased immobility, depression, other health issues that come into play, and then, unfortunately, several people opt to end their own suffering. And I'll let you fill in the blanks. And that is absolutely terrible. And again, one of the reasons that we want to get our message out on this channel is to help give those people a little bit of hope, a little bit of sunshine in their life to say, hey, there are options, friend. There are options. Don't give up. So let's address the bigger issue. The problem with social media is that it amplifies extremes, right? It's all clickbait to some extent. And usually the squeakiest wheel will get the most attention. If something makes the news, it's sensational. Oh my goodness, look at this. There's a patient or two patients in this case, which we'll get to, two patients that developed an irreversible spinal cord injury. That is terrible. I'm not trying to minimize it. That is terrible. But that on its face, without any further context, is, I think, misleading, especially if we're trying to use that information to dismiss an entire therapy. I mean, by the same logic, we could dismiss all of opioid therapy. 10 times over. We could dismiss, anti-inflammatory medication. I actually need to do an episode on anti-inflammatories versus opioids. There are several thousand, hundreds of thousands of complications associated with non-steroidal medications, such as ibuprofen, naproxen, things of that nature. And so again, it comes back to risk management, right? Older people, based on how their brain works, tend to do better with opioids, at least low-dose opioids, tend to do better than with opioids than they do with anti-inflammatories. Anti-inflammatories will raise your blood pressure, increase your risk of heart attack, increase your risk of stroke, shut down your kidneys, shut down your liver, exacerbate any stomach issues, right? It's like a leading cause of peptic ulcer disease, ulcers in your stomach. Anti-inflammatory medications are. So there is no zero risk game in this practice. It's all about what is your risk compared to, right? Younger people tend to do better with NSAIDs. Younger people tend to do worse with opioids, but that's not to say you shouldn't get opioids as a younger person. It just means you might have a higher risk on the average, looking at big populations. But everybody's risk is different when you are just one doctor, one patient in a room. Worst case outcomes spread faster than balanced data. Anecdotes change perception faster than statistics. So the point I'm trying to make is risk perception is not the same as actual risk. If you're familiar with Dr. Ben Carson, he is a neurosurgeon, retired now, and I suppose he made his initial fame by separating conjoined twins at the brain. They were conjoined at the head, and nobody wanted to take on the case. Ben Carson took on the case. If you don't know that story, you should read about it in his book. He's written several books. The one I'm thinking of is Gifted Hands. Incredible story. Of course, he's made news in recent years as being a presidential candidate, so you might remember him from there. He talks about risk a lot. And his essential conclusion is that everything in life has risk. It's about how you understand it that will change your application. And so he wrote a book called Take the Risk. And if you haven't read that, I highly recommend it. It's tremendous. He talks about there essentially how, again, everything has risk. Driving your car to work has risk. Being alive has risk. And so it's not about eliminating risk. It's about understanding it, having respect for it, and realizing what it is that your goal is. What are you trying to accomplish? And being okay with an acceptable amount of risk. Back surgery, by the way, has a lot of risk. I know all of my back surgeons that may be watching this are going to be like, oh, no, it's fine, it's fine. But that's like the number one reason we do spinal cord stimulations is because back surgeries that don't work. But, I may be coming from a biased perspective. I don't see back surgery getting the same hate necessarily that spinal cord stimulators do. We're all just trying to help. Now, yes, there's bad players, and unfortunately, they often get the headlines. But But everything has risk. There's reasons why we do the things we do, and there's reasons why we have informed consent. It's so important to have informed consent, and that you are actually informed of the risks, and that risk is acceptable to you. A 1% chance may be good for the physician, but it may not be good for you. And that's okay too. A 0.1 chance of permanent spinal cord injury may not be an acceptable risk for you as the patient. And that's okay. So I don't want to turn this into, well, stimulators are actually much worse than you're letting on, or opioids are actually much safer than you're letting on. That's not what this episode is about. The episode is about understanding risk and teaching you how we manage it and how we should manage it. Not only as physicians, but as patients, so that we can approach a problem with a sound mind and a balanced approach. So that's the conclusion. If you're living with chronic pain as a patient, if you're living with chronic pain, you deserve a balanced approach. You deserve to understand the risks of procedures, the risks of medication, and the risks of doing nothing. Pain management is not about defending one treatment over another. I know it's become that, and I think that's a shame. Oh, the big anti-opioid movement in pain management. The big pro-intervention movement in pain management. There's room for everything. There has to be room for everything. Now, the point of pain management is to reduce overall harm, right? Let's go back to the 4 ethics of medicine. First, there's do no harm. As a physician, we are obligated by oath to do no harm. The second one is to do good. We must aim our pursuits to actually not hurt you, but also help you. And then, of course, the third medical ethic is patient autonomy, respecting your right to choose. And then, of course, justice. So that the just application of our medical treatments. And that's what it's all about. When it comes to, you know what I'm going to do? This message is now for the young doctors in the room. If you're thinking about going into medicine, or you're a resident, a fellow, a young attending, and you have concerns about certain risks involved in certain things, right? Because a lot of what you're being taught, speaking to the young folks, is never prescribe an opioid. That's not a secret. Never prescribe an opioid. I went to a fellowship, very nice fellowship, very, prestigious, and all the attendings were extremely well-versed in their field and intelligent and wise. But my practice of actual prescribing long-term opioid therapy was very minimal. And the idea is that, it's just harming people. It's a road to nowhere, and it's the risk-benefit ratio is not there. Well, yes, if you were to apply the headlines and large-scale statistics to every patient, you could make that argument. The problem is the patient that gets caught up in that actually needs the opioids. Not to attack anyone personally. That's not what we're trying to do here. But if you call yourself a pain management doctor and exclude opioids, to me, that's calling yourself an endocrinologist and not giving anybody any insulin. Okay? You're a pain doctor. Be a pain doctor. I'm not saying run a pill mill and give everybody opioids. No. Like I said, not every patient should get opioids. I think we can all agree on that. Probably most patients should not get opioids, but a lot of patients do need opioids to live. And by the way, the same thing is true with spinal cord stimulators. When you think about it, I talked about this in my last episode. I believe it was my last episode, the actual number of spinal cord stimulators. I mean, we're talking 30,000 to 50,000 stimulator implants per year. When you divide that amongst 2,500 pain doctors, that's like 2 or 3 stimulators per month. And when you're carrying, let's say, a population of 800 to 1,000 patients, like nobody is like bankrolling their clinic based on the introduction of spinal cord stimulators. So again, most people are not candidates for spinal cord stimulators. The point I'm trying to make is that you should not, as a young physician, you should not practice fear-based medicine. Fear has no place in the practice of medicine. Responsibility does, respect does, informed consent does, making sure you understand the risks, of course, but fear has no place. We should not practice reactionary medicine. We must study risk deeply. We must select patients carefully and then consent honestly. That's what it should boil down to. Your job is not to eliminate criticism. It is to think clearly. So that's what I want to leave this on. Pain management is risk management. Every path carries danger. The art of medicine is choosing the least harmful, most effective option for that patient at that time. The real danger isn't risk. It's misunderstanding it. I hope that was helpful for you. For those of you sticking around, we're going to be here in the live in just a couple seconds, and because I can't wait to see what your questions are.
I know I've got some.
All right. What's up, Kevin?
All right. So I think it's safe to say that opioids are not allowed in professional sports. Right?
That's a question for Jose, actually. I'm not for sure on that.
I thought that would be it. You're probably right. Well, when you start talking about it, the one thing that keeps coming across me and across my mind is, well, what if spinal cord stimulators were not considered performance enhancing?
Oh, I don't know. I don't know.
Because, like you say,
Ooh, there's a lot in the comments, though.
Right.
Yeah,
things that are performance enhancing. Yeah. You want to hit it one time? Go ahead.
I have one. Do the SCI or leads fuse with the body?
Oh, okay.
So
do the spinal cord stimulator leads fuse with the body? That's a great question. They don't necessarily fuse. It's still separate entities. But yes, the longer you have them in you, your body does form, let's call it scar tissue around those leads, which does help hold those leads in place over time. So yes, that's actually a good thing. We want that to happen because it does minimize your risk of lead migration over time. But it's not so tight that I can't remove it. We can still remove it. Yeah.
I have two more. Do we see any sex-based differences in spinal cord stimulator utilization, or are implantation rates fairly comparable between men and women?
Good question. I would have to look that statistic up specifically. Yes, for whatever reason, the complication rate seems to be slightly higher in men than in women. I have my own theories, perhaps, why that's the case, although I have no idea if it's true or not. Probably there's some anatomy differences. Men may have more narrow canals naturally than women do. Generally, in my experience, women may be a little more compliant with stopping anticoagulants and aspirin and all that stuff. It seems like most of the men that I treat, and myself included, I rely on my wife a lot did you take your vitamins today? Did you do this? Did you do that? And I'm like, I don't know. I'll just do what you tell me to do, right? So there may be an issue there. But again, I'm shooting from the hip. I have no idea if there's a difference between the sexes there. As far as implantation rate, yes, nationally the rate is, let's say you have a trial, 60 to 70% of those with the trial will go on to have a permanent implant. And so what that suggests is that we are selecting the right patient, so to speak, 60 or 70% of the time. That will vary, of course, between practices. My practice is actually a little bit closer to 90% because I'm very selective on who I put the stimulator in. And actually, I think that really brought the number down because there was one patient I was like, this isn't going to work for you. But he was very, let's say, determined. He met all the criteria, so it's not like we were coloring outside of the box, but I just didn't think it would work for him. And it didn't work for him. So he didn't go on to the implantation. But hey, part of respecting patient autonomy, right? But yeah, that's the average across the board, 60 to 70%.
Also, do genetic conditions like EDS affect how spinal cord stimulators work?
You know, that's another great question. The problem with EDS, again, it's relatively rare across the board, I think, for just in general, but also for spinal cord stimulator patients. I don't see any red flags right out of the gate. Why that would be a contraindication to implant a spinal cord stimulator. I think the big thing is just, is there room in your spine? Number one. So again, the importance of the MRI and looking at those images. And then making sure that you have a pain syndrome, let's say, that would respond well to a spinal cord stimulator. I think that's some of the misunderstanding about stimulators also is that they're not for everybody. Generalized chronic pain, multiple joint arthritis and things of that nature, it's not really designed for. It's designed for primarily neuropathic or nociplastic type pain that's coming from nerves or in the spinal cord. And it's relatively focal. So if you have a complex regional pain syndrome that's affecting one limb, or if you have failed back surgery syndrome, which is what we refer to, generally speaking, persistent pain after a back surgery, where there's ongoing nerve pain, that type of thing, that works fantastic for that. Diabetic neuropathy, also, these are all indications for spinal cord stimulation. So I think that can be very helpful for those conditions, but not every patient every time, but not by any stretch. Yeah.
We had several.
Hopefully that helped make some things a little bit more clear for you and gave you some empowerment when it comes to understanding the real risk of pain medicine, the conversations you need to have with your physician, and the conversations your physician needs to have with you. If you found this to be helpful, please log out, leave us a thumbs up, put a comment. The comment tonight, I'm going to say, is risk management. Okay? Pain management is risk management. We'll see you next Monday. Take care.